All right. Hello, everyone. Thank you so much for joining us for New Energy Conversations with Early Career Energy Researchers. Thanks for your patience as we got the webinar up. We had a couple of technical difficulties, but we are here now. So thank you so much for being with us. Um, so I am Megan. I am the manager of academic initiatives at the Irving Institute for Energy and Society here at Dartmouth. And I'm delighted to welcome you all here today for this speaker series. This is part of our New Energy Initiative, which aims to empower and raise the profile of early stage researchers in energy and climate. And so part of this is highlighting early career scholars on this webinar. And then we also host an annual in-person New Energy Summer Summit that helps early career energy and climate researchers, scholars increase their capacity for interdisciplinary scholarship and collaboration. So I'm super excited to introduce today's moderator and our speaker. But first, just a quick note. After the talk today, we'll have an opportunity for discussion. So feel free to enter your questions for our speaker using the Q&A icon at the bottom of your Zoom screen. And you can do that at any time during the program, and we'll get to as many questions as possible after the presentation. All right, so now I am delighted to kick us off by introducing our moderator for this session. So Dr. Sarah Crockett is an emergency physician and specialist in wilderness medicine and planetary health. Her 25-year career in medicine has taken her to all corners of the planet and has led her to focus her career on supporting a healthy planet for healthy people. She founded a fellowship in wilderness and austere medicine at the Dartmouth Hitchcock Medical Center and also founded the Alliance for Climate and Health at Dartmouth. Her work in planetary health focuses on building bridges across disciplines to look for new and innovative solutions to wicked problems like climate change and healthcare disparities. As an assistant professor in emergency medicine and public health, Sarah focuses on educational innovations and curriculum development, teaching courses on health and climate for both medical and public health students at Dartmouth. And she also serves as assistant dean of career advising at the Geisel School of Medicine. Thank you so much for being here, Sarah. I'm going to pass it over to you to introduce our speaker.
Thank you, Megan, and I'm truly honored to be here with Kate. I had the opportunity to look over some of her amazing research, and this is so incredible to have her as a guest speaker today. I'm inspired by the work that she's done, and I'm excited for her to share some of her expertise with our community. So just to give you a little glimpse of the work that Dr. Burrows is doing, she is an assistant professor at the University of Chicago and the Department of Public Health. And Dr. Burrows is an environmental epidemiologist. Her research focuses on the relationship between climate and weather-related extremes and public health. And as an emergency doctor, natural disasters, everything that goes along with that, responding to, preparing for, and the downstream consequences, not just the physical health, but the mental health consequences are in the forefront of my mind because I do see people, and we've had extreme flooding and other heat-related injuries that I care for in the emergency department. This isn't a future problem. This is a real problem that we're seeing in healthcare and public health right now. And having researchers like Kate bring that to the forefront and say, you know, this is real. These are patients who and communities who are experiencing these problems is so important. She uses mixed methods and qualitative research, as well as qualitative and community-based research in local settings, which, again, we work a lot on local problem solving here at our community. And so I really appreciate that approach. And her research really has spanned a wide range. Kate, again, it was an honor to review some of the incredible publications that you've gotten out there. Everything from climate and weather-related disasters, hurricanes, floods, landslides, extreme heat, and also, again, the mental health side of things as well. She's been published in the Lancet Planetary Health, Nature Communications, Nature Mental Health, Nature Ecology and Evolution, and has been invited to speak around the world on issues related to climate change and health. So before joining faculty at the University of Chicago, Dr. Burrows was a postdoctoral fellow at Brown University, and she received her PhD from Yale University School of Environment and her MPH and BA from Columbia. So Dr. Burrows, we are so excited to have you join us today and excited to learn from you and your wealth of knowledge on climate and health.
Thank you so much for that very warm introduction. It's very nice to be here. I was hoping to try to speak at some point last year, and it got postponed. So it's been a long time coming, and I'm really excited to speak with you all today. So, if I understand correctly, I'm going to try to keep this to about 30 minutes, so that we have plenty of time for questions. So I will start by sharing my screen. Okay, does this look okay? I think it does. I'm going to operate as if it is.
That looks great.
Okay, perfect. Thank you. All right. Well, Sarah, I feel like you gave a great introduction to me, so I'm not going to spend too much time talking about myself. But thanks again for being here, everyone. I'm going to be speaking today about hourly temperature exposures and psychiatric emergencies, specifically focusing on some work that me and my colleagues are doing based in Boston. So with those colleagues in mind, I just wanted to do a sort of brief overview of, the people who I've been working on this project with, who are really excellent, our wonderful collaborators across multiple different universities, many different states. Obviously, I've spent a lot of time on the East Coast, so a lot of East Coast representation here. So thanks to all of these folks who have been instrumental in this research. This work also has been supported by NIEHS, as well as some internal funds from several of these institutions. Okay, so I just wanted to start with like a very brief introduction of how heat actually affects the body. I know not everyone here works on heat, so let's just do like a quick overview here. So we know that the human body responds to heat in two primary ways. So the first is by redistributing blood flow through the widening of blood vessels, the process of vasodilation, which allows more heat to be lost to the environment, thereby reducing our body temperatures. And the second thing that happens is that we sweat, right? So we secrete sweat into the skin, which then evaporates and removes body heat that way. And both of these are important because when it gets really hot, our bodies need to cool down. But during times of extreme heat, and especially during periods of prolonged extreme heat, these can lead to adverse health effects as they become taxing on the body's system. So, in particular, we are pretty concerned about folks in terms of cardiovascular issues during high heat periods. For older adults in particular, we know that CVD is the number one cause of death during high heat periods. So this is a key risk that we're very concerned about during periods of high heat. And the second system of the body that we're particularly concerned about is the renal system. So of course that process of sweating can lead to dehydration, which increases the risk of kidney failure during extreme heat periods. So we see lots of issues with the heart and with the renal system during these high heat periods. But what you don't see represented on this figure is the potential impacts on mental health. We see a little bit, they talk a little bit about confusion up in the nervous systems, but we're not really talking about mental health. This is very much a physical health diagram. So what are the potential relationships between temperature and mental distress? So there's still need for work on causal pathways here between extreme temperatures and mental health, but we do think there are kind of two key mechanisms that could be really important here. So the first is changes to health-seeking behavior, and the second is more physiological impacts. So changes to health-seeking behavior could include things like reductions or disruptions to sleep, or reductions in physical activity. And these are important because these are activities that we know tend to promote good mental health. And so when you take them away, we think that people may increase their risk of mental distress. And the sort of second dynamic here is the physiological impacts. So we think that this could have to do with inflammation in the brain, which could lead to mental distress. So some of my more clinical colleagues are working on some really interesting research trying to actually measure these impacts on the brain itself in leading to these issues of mental distress. One thing I do want to note here is that generally, unlike when we're talking about some of those disasters that Sarah mentioned earlier, like hurricanes, landslides, floods, these big major events, we generally don't think that extreme temperature creates new or precipitates new cases of mental distress or psychiatric emergencies. Rather, we think that they exacerbate pre-existing illnesses or underlying conditions, resulting in sort of like an acute episode of distress. There are other more complex pathways that you may see in the literature. These are more distal links between temperature and mental distress, especially through things like crop security, which can lead to economic instability for folks who are working in agriculture. There's some really interesting literature specifically out of Australia that shows a risk of farmer suicide during periods of high heat and periods of drought associated with this, or potentially associated with this causal pathway. But I'm an epidemiologist by training, and so I'm really focused on this sort of more acute effects and the short-term links between temperature and mental distress, rather than trying to plot out some of these more distal pathways. But just to sort of flag it here, this conceptual diagram seemed a little bit too reductive without mentioning some of that other literature. So what do we know about temperature and mental health? So this is a very, very brief review of the state of the epidemiological literature. So a lot of the research we sort of started with focused on high-risk groups of people who were most likely to be exposed to extreme heat. So these were people who were working outside and had that occupational exposure. And we found that occupational heat exposure and heat stress was associated with increased risk of psychological distress in a number of different cohorts. And more recently, this research has been expanded to look more at the general population. So if you're not someone who's exposed to really severe heat for long periods of time during your work, do you also have this increased risk on high heat days? And research suggests that yes, you might, or one might. So we find an increased risk of hospitalizations for a number of different mental health outcomes, including substance use disorders, anxiety, stress-related disorders, mood disorders, and schizophrenia across the entire country as temperatures get hotter. And also, research has shown increases in more general mental health difficulties, as well as impacts on mood, sort of like positive, negative valence. These last two studies are really interesting because they're drawing on, or the last study at least, is drawing on some social media data. So it's kind of a novel way to try to capture these impacts. But overall, we are seeing that it's not just people who are exposed occupationally to really severe temperatures, but also the general population where we're seeing these associations. Something that I think is particularly interesting about mental health, if you work on heat at all, you might know that we tend to think that the effects of heat accumulate on the body over multiple days. So that sort of cardiovascular risk that I talked about, we don't necessarily see that increase in cardiovascular mortality on the day of a heat wave. It sort of delays for a couple days, and then we see a big impact. What's interesting is that some of this preliminary research on heat really does suggest that these effects, or I'm sorry, on heat and mental health, really suggests that those mental health effects are somewhat more acute. So they're happening mostly on the day of the high heat, on a specific high heat day, maybe a little bit the day after. And this is pretty different looking than some of our physical health outcomes. And this will be important as I sort of move forward, why we're talking about these really acute exposures. So with that very brief, literature review, there obviously are a number of different gaps in our knowledge. So the first is our ability to identify and include vulnerable populations in our study. So there's been some big data studies recently that are really excellent, but are relying on private insurance claims data, which sort of by definition excludes people who are uninsured or publicly insured, who we think actually might be at increased risk due to higher rates of unstable housing, lower SES, lower access to cooling resources, and maybe some other pre-existing conditions. So this is a pretty big gap that I'm particularly interested in. This is a major issue of a lot of the research that I do, and a question that we kind of grapple with all the time when we're picking data sources, right? Like who is actually included in this data, and how does that change our interpretation of the findings? Second key gap in our knowledge is that we have a need for improved exposure assessment. So if you work in environmental health, I feel like we're kind of obsessed with this idea of exposure assessment. Basically refers to how do we know that a person was actually exposed themselves to extreme heat. And previous studies have used pretty coarse spatial resolutions, so something like a 4x4 kilometer grid, which may not seem that big, but actually is kind of large. And that may result in exposure misclassification, meaning that we are not able to capture sort of small scale variations in temperature, and we're relying on these larger estimates that may be misrepresenting, misclassifying people's exposures. And relatedly, we also see that most studies, including my previous work, use mostly daily estimates. So we're saying how hot was the temperature on the day that a person had a mental health crisis. And that limits our ability to explore diurnal variation, and it limits our ability to explore hyperacute effects. And again, this is important because we're seeing that the effects of temperature on mental health seem to be happening a little bit faster than some of the effects that we see on physical health outcomes. So as you might imagine, these gaps in the literature are leading me to talking about a specific study that my team is working on now. We call this the PRIME Boston study. PRIME stands for this very long full title, Prevention of and Response to Incidents of Climate-Related Mental Health Emergencies in Vulnerable Communities in Boston. And that is such a mouthful, so we call it PRIME Boston. And our main research objective here is to evaluate the temporal variation in the relationship between temperature and psychiatric emergencies in a high-risk population in Boston. So our key contributions are that we're using highly temporally and spatially resolved data to really address that gap that I just mentioned. we're focusing explicitly on a high risk and understudied population in Boston. I'll talk more about this data set in the next few slides. And we're using quite a lot of longitudinal data. So we have many years of data on emergency department visits. So we can really look at a nice sort of a nice large sample of people over a long period of time. So I do think that there's an interesting question here of why do we actually care about the spatial resolution? So I told you that we, are kind of obsessed with this in my field, the idea of refining our exposure assessment, but does it really matter? Like I said earlier, 4 by 4 kilometers seems pretty small. Is this actually an issue? And I would argue that yes, it is actually an issue, and we do need to think about refining our spatial resolutions. You may have seen some images like this in the past, but what I'm showing you here is a couple of different images that show that historically redlined communities in Boston tend to be hotter today than communities that were deemed to be more desirable back in the 1930s, 40s, and 50s. So you can see those more desirable communities on the left-hand side here, and the communities that were considered to be hazardous or less desirable are on the right-hand side here. And you can see that the temperature tends to be hotter in those communities that were deemed more hazardous. And this has to do with historical investment patterns, so more impervious surfaces, less access to greenness, less sort of cooling features that would help to make those areas less hot. So you can see that this is sort of a structural problem, and Boston is not a big city, right? You guys are not very far from Boston, for those of you who are at Dartmouth in person, and you likely know that we're not talking about a lot of space here. And so if we were to use this sort of large scale resolution temperature measure, we would kind of be collapsing these differences. And we know that these communities that are more vulnerable or potentially are more vulnerable tend to be living in these areas that are experiencing higher heat. So we're actually underestimating their heat exposure. So with this in mind, this is really a key contribution of this project. So we're using highly spatially and temporally resolved data. So this is a figure from my colleague's paper that shows the data that we're using in this project. We have a 1 by 1 kilometer grid of temperature predictions for every hour during our study period. So we're able to look at a lot of really interesting and high resolution variation. So the sort of second question then is like, why am I talking about temporal resolution? So I mentioned sort of briefly that we're using these hourly estimates. I've just told you about why the spatial resolution matters, but the reason we think that the temporal resolution matters is that we hypothesize that the temperature mental health relationship may vary diurnally, so throughout the day, due to potentially fluctuations in our physiological stress responses, our thermoregulatory capacity, or neurochemical function. And so by understanding these temporal factors or temporal patterns, we might be able to help differentiate between our direct physiological pathways and our indirect or behavioral mechanisms that I showed in that earlier diagram. And ultimately, in this project, we're working closely with our clinical partners who are particularly interested in understanding these diurnal patterns for the sake of developing targeted prevention strategies. So for example, maybe changing clinical protocols or research allocations during extreme heat events. So having this additional knowledge about actually the temporal resolution or about the temporal variability might be able to help improve the way that we respond to these extreme heat events. So just some brief information about our data. So this data set is referred to as the BEST data. It's the Boston Emergency Services Team. And so this is a really unique data set. It's a large psychiatric emergency services program that's based in the greater Boston area. Serves parts of Massachusetts, but predominantly services folks who are living in the Boston metropolitan area. And this program was designed and primarily serves people who are either uninsured or publicly insured. So we're really capturing this more vulnerable population that has not been included in other studies. So BEST services about 18,000 people each year. We have data from 2005 to 2021. The analyses that I'm about to show you are all focused on 2005 to 2019 because we weren't really ready to deal with the issue of the pandemic and how that might affect mental health. So we've excluded those years for now, and we're just focusing on the pre-pandemic period. And there are a number of different ways that people can interact with the BEST system. So this is obviously got a lot of stuff going on here, but I just want to demonstrate that there are different ways in which a person could get into the BEST system. So a patient who's in crisis could either walk into a BEST ED or an urgent care center. They could call 911 and be referred to a BEST ED, or they can be referred by a community member. So this is common in school-based programs, and also often actually by like friends and family members who will call in and refer a community member to a best ED. This call center actually can dispatch a mobile crisis unit that can transport people to the emergency department, or it can sort of deal with cases just in that mobile crisis unit. For this analysis, though, for now, we're just focusing on the best ED visits. We'd like to expand this moving out, but because it's a bit more complicated in terms of how people actually interact with the system, we're choosing just to focus on the ED visits for now. Some brief descriptives on this population. So in total, we have about 75,000 individuals in our sample, but we have people coming in quite a lot. So we have about 18,000 encounters per year, which indicates that the number of patients that many of our patients are actually repeat patients. So here I'm talking about just patients, whereas previously I was talking about encounters, and the encounter is actually our unit of analysis here. I do just want to flag that compared to the Massachusetts population, we have more participants or more patients in this study who are non-Latino Black and Latino than in the Massachusetts population based on this is actually 2021 statistics. And almost 14% of our population participants were experiencing unstable housing at the time of their encounter with the best ED. And lastly, as I mentioned, about 80% of best participants are best patients are publicly insured, which is much, much lower than the Massachusetts population. So we had, as I said, a lot more encounters than we had individual patients. Our first process, which was actually quite a large process, was geocoding all of these encounters. So we started by taking all the encounters, we removed folks who had missing data on their street address, and we built an offline geocoder. Happy to talk more about this. This was for reasons of privacy so that we didn't have to upload people's addresses to the cloud. And we used that offline geocoder to geocode our encounters. We were able to do that pretty successfully. So we had a 96% success rate of the geocoder. And that means that of the total number of addresses that we started with, we were able to geocode about 83%. So we feel pretty good about this. It was an arduous process, and I don't look forward to updating it in the future, but it does open the door, I think, to a lot of different research beyond focused on heat using these best data. So once we had these GPS coordinates, we linked each person's residential address to the temperature, so we matched each encounter to the temperature of the nearest centroid of that 1 by 1 kilometer grid for the hour preceding their ED visit. So if a person went into the ED, for example, at 8:45, we pulled the 8 a.m. temperature at that nearest centroid to where the person was residing. We also pulled hourly data. So not only did we pull that temperature right before the person went into the ED, but we pulled the hourly data for the 24 hours preceding the encounter. So we looked backwards and created this lag period, which will be very important in our analyses. Once we did that linkage, in this project, we used a case crossover study design. So we used a time stratified matching procedure in which individuals who were experiencing psychiatric emergencies, so someone who came into the best ED or was transferred into the best ED, was matched to themselves on the same day of week within the same month and year. So this approach helps us to control for seasonality and for long-term trends. And this case crossover study design is commonly used for exposures like temperature, which tend to be relatively short. So it means they affect someone during a really short period of time, and then they don't continue to affect someone in the many, many months, many weeks after their individual exposure. So what that means is for each individual case, so if a person went into the ED at 8 a.m. on May 8th, which is a Wednesday in 2019, we selected controls within the same month. So we pulled controls for the first Wednesday of the month, the third Wednesday of the month, the fourth Wednesday of the month, and the fifth Wednesday of the month. And so that means for each case, we had about 3 to 5 controls. If another case happened, like if a person had gone back into the ED on this Wednesday, for example, that would not be eligible to be a control. So we did write that into our code. That didn't actually happen, I don't think, in any of our data, but we did sort of try to deal with the issue of someone coming back into the ED. And while we did see a lot of these repeat visits, they weren't usually over that like very short period of time. And then for each of these cases and for our controls, we pulled the temperature data using the process that I just described on the previous slide. And so ultimately, this approach allows subjects to serve as their own control, which helps to control for both observed and unobserved individual level confounding. So after we set up the study using this case crossover approach, we used a mixed effect conditional logistic regression for most of our models. So what we did is we modeled the outcome, which is any encounter, any PsychED encounter in the best data, modeling the impacts of ambient temperature. So we looked at max, mean, and min of the overall temperature, but we also looked at our hourly temperature. And we adjusted these models for strata, so that captures the case control groups. There's a mixed effect in there, relative humidity, and for federal holidays, because we know that there's differences in terms of when people go into the hospital, depending on holiday periods. We also incorporated a natural spline for both temperature and for relative humidity. And then we applied a distributed lag nonlinear model, we call this a DLNM, to look at our lagged effects across the 24-hour period. So you've probably gathered some of the research questions thus far, but I figured I would lay them out again here just as we get into some of these results. So the first question, and the main question we were interested in here, is there an association between hyperacute, so hourly temperature, and mental health ED visits? And do these effects accumulate over the course of the day? The second question is, what is the magnitude of exposure misclassification when using our daily temperature data? So again, most of our previous studies, I think actually all of our previous studies, to my knowledge, are using an average for the day of a case. So we wanted to try to quantify what is the actual magnitude of exposure misclassification when we use that daily temperature data, or is that actually like an okay approach? And then the last question was, what is the impact of daytime versus nighttime heat? Trying to capture that impact of sleeplessness, which I mentioned is one potential part of the causal pathway. So for each of these, I'm going to present some results in the next few slides. So the first question, again, is there an association between these hourly temperature and mental health ED visits? Is shown on this slide. So what we have here is on the x-axis, we have temperature going across the whole temperature spectrum, so from -10 to 30 degrees across the entire year. On the y-axis, we have an odds ratio, and again, we're looking at the temperature in the hour before admissions. And what we see is that as our temperature increases, there is an increase in risk of ED visits. Interestingly, we see that risk actually starts pretty low. So the minimum morbidity temperature, which is what this curve is centered on, that means the temperature at which a person is the least likely to go into the ED, was the coldest temperature. And so for every degree Celsius that it got warmer than that very cold temperature, we see an increase in risk. Though there is maybe a little bit of a plateauing effect here at around 20 degrees, which is kind of interesting, especially given that 20 degrees is fairly moderate in terms of degrees Celsius, of course. So the way we would read this curve is on a day that the temperature is 30 degrees, a person has about a 1.15 times the odds, or is at 1.15 times the odds of going into the psych ED compared to on a day where the temperature is about -10 degrees Celsius. So then we looked at whether these effects accumulate over the course of the day. And so this curve here on the top left is the same figure that I just showed you on the previous slide. But now what we did is we looked at lag periods, a number of different lag periods from 0 to 6 hours before the admission, 0 to 12 hours before the admission, and 0 to 24 hours before the admission. And what we see is as we pull out that lag period, so we look at the cumulative effects of the preceding 6, 12, and 24 hours on a person's risk or odds of going into the psych ED, we see very, very similar patterns, but that risk continues to increase as we extend out that lag period. Interestingly, we see actually this plateau turning a bit more into a decline, which is kind of interesting. So this is something that we're spending some time trying to interpret now, where it seems like in the 24-hour, when we're looking at that 24-hour lag, we actually see a lower risk at the highest temperatures, which might be behavioral potentially, where people are now actually, it's hot enough that people are like avoiding going in to the ED. But this is something that we're still working on interpreting. And so I think a couple things that are interesting here. The first is what I've just mentioned, that there is this sort of accumulation of risk across the 24-hour period as we sort of look at this extended lag period. But I do also just want to call attention to the fact that on this first figure that we see an impact is pretty striking, because these are very, very severe. It's a very severe outcome to look at a psych ED visit, right? So we're talking about mental health, but this is a pretty severe manifestation of mental health, right? And so the fact that we see this association between the hour of temperature and that severe outcome, I think is pretty striking. And to me, what that indicates is that there might be a lot going on, like the sort of, this is maybe like a tip of the iceberg type of situation where we're not capturing people who don't make it to the ED. We're not capturing people who choose not to go in or who don't want to get treated. We're not capturing people who have subclinical or preclinical mental illnesses. This is just looking at these like pretty severe outcomes. And so I think that's fairly striking. And the fact that we see it so cleanly across all of these different hourly periods, I think is pretty notable. So our second question here, as I mentioned, was what is the magnitude of exposure misclassification when we use daily data? What I'm showing you here is just a distribution of case visits by hour of day. So just when people went into the ED. And I think this is kind of like reasonable. This sort of jives with my intuition, which is that, people don't go in a lot in the early hours and they're more likely to go in kind of midday. But what this means is that if most people are going in kind of around, it looks like maybe noon, there's a lot of people for whom we're misclassifying temperature or we're misclassifying exposure when we use the daily temperature. So we know that our maximum temperature usually occurs sometime like around 1 or 2 p.m. during the day, maybe a little bit earlier, say noon, but sometime in this period, which means that for all of these cases, if I say that the temperature on May 8th, the high was 95 degrees, which surely I hope it won't be, but if it was, that means that for all of these preceding cases, they actually went in before that temperature happened. So this is an example of, I think, like a real misclassification. However, something that is important is that, a lot of these cases in the middle of the night, those are much fewer, right? So we're potentially misclassifying fewer cases than we would be if we used different temperature exposure. So what this means is we actually calculated, or sort of how we proceeded with this is we calculated the two different plots here. The first in green is just looking at that day of mean. So the day a person went in, what was the mean temperature? And the purple is showing a 24-hour mean. So that means that we looked backwards using that hourly data to capture the mean temperature over that 24-hour period to see if that was more accurate, because that's what a person definitely experienced leading up to their hospital or their psych ED visit, right? And so what I think is interesting here is that despite the fact that we see a lot of cases where maybe we're getting the temperature wrong, basically, because that is sort of what this means here, it's actually okay, right? These curves are pretty similar. We've done some formal heterogeneity tests, and I don't think you need to see the results to see that there isn't a statistical difference here. And this is good, right? Like this tells us that in general, it would suggest that using this mean temperature is actually an okay estimate of the type of temperature that a person experienced. And this is likely due to the fact that we don't see a ton of dramatic variation in temperature in Boston day to day. Sometimes it doesn't feel that way, obviously, but overall, this suggests that those like huge temperature swings are not super common. And if the day of mean is sort of accidentally nudged by one day or another, we're actually not misclassifying by that much. And likewise, when we look at the maximum temperature, it looks pretty similar here too, right? So the day of max versus the 24-hour max, those curves look pretty similar, again, indicating that while there's a reason to look at this improved exposure assessment in that we can actually look at these variations across smaller scales, if what you want to know is a day of estimate, using that 24-hour maximum doesn't really help you that much more than just using a maximum temperature. So again, generally it feels like this is pretty good news for some of the work that we've published on this topic already. All right, and so then in the last couple of minutes, I wanted to talk a bit about our last research question, which was how do nighttime versus daytime temperatures, so basically hot nights versus hot days, impact our mental health ED visits? So what this figure is now showing us is instead of looking at a temperature on the x-axis, we're looking at the hours since temperature exposure. So these are our lag hours now. So this means that hour 0 is the hour of an extreme heat exposure. And then, hour 24 is 24 hours after that high heat exposure. And we're looking at a threshold here now. So we're not going across the temperature distribution, but instead we've defined our threshold as 90 Fahrenheit to count for a hot day and 78 Fahrenheit to count for a hot night. And these definitions were identified by the Boston Heat Action Plan in 2022. These are the definitions that they use to talk about hot days and hot nights. So we varied this a bit in some sensitivity analyses, and if we nudge it up or down, we see pretty similar findings. But overall, what this figure shows, and the way that I would interpret this, is that the blue line tells us that at the time of, if it is hot that day, a person has about, or in that specific hour, so a day that is an hour that is above 90, there's a more than 1.1 times the odds that someone will go into the psych ED to in this best population, and that increases again over a 24-hour period. So this is good because it's sort of consistent with what I showed on the previous slide, where we see this cumulative effects over time. What's interesting here, though, is that we don't really see much difference between if it was a hot night that sort of preceded their ED visit or a hot day that preceded their ED visits. However, we also had wanted to look at some effect modification based on some sociodemographic characteristics. And one of the ones that we were really interested in relation to sleeplessness was housing status. So I mentioned that about 14% of our population was experiencing unstable housing at the time of their psych ED visit. And so what we did is we stratified our data set based on folks who were housed at the time of interacting with BEST and those who were unhoused at the time of interacting with BEST. And what we see is that for the housed population, we see fairly similar curve to what I showed on the previous slide, which is whether it's hot during the day or hot at night, it doesn't really matter. But we do see a pretty big difference and an interesting divergence when we look at the unhoused population. So this suggests that above, the sort of moderate temperatures of like 15, above these, or I'm sorry, after a certain number of cumulative hours, we start to see that the hot nights actually are more strongly predictive of increased risk of psych ED visits compared to hot days. So this means that, in the sort of 12 to 24 hours after a really hot night, we see a stronger increase in risk of psych ED visits for this unhoused population. Something that is notable that I think we're still trying to interpret here is that risk is lower than the housed population, even after we see this kind of split. We're not sure what to make of this. It could be related to, like willingness to interact with the BEST system, knowledge about the system, ease of accessing someone. So this could be more behavioral. But overall, we do think that these findings are quite striking in terms of seeing perhaps that this housed population is being somewhat, like protected from the extreme heat effects that an unhoused population is not. And that in particular, sleeplessness could be one notable pathway because of these high nighttime temperatures. All right, so to summarize, our key findings suggest that we do see hyperacute exposure to higher ambient temperatures is associated with increased risk of mental health ED visits. We also see that these effects accumulate over the course of the day. So we see that hyperacute effect, but it is not as strong as the sort of cumulative effect over the course of the day. We also did find some evidence of exposure misclassification based on when people go in, and some additional analyses we did that suggested that for those morning visits, we are off if we use that daily temperature. However, ultimately, we find that these daily measures are likely adequate for most studies. So if you're interested in looking at the sort of overall effects across the day, using that daytime T-mean or T-max, at least in Boston, is not too much of an issue. There might be other places where we see more of a swing day to day, in which case that might lead to more exposure misclassification. But at least in this city, it doesn't seem like that's too much of an issue for our future work and for our previous studies. And lastly, we saw that both hot days and hot nights increase the risk of mental health ED visits, but hot nights appear to have a stronger effect for people who are experiencing homelessness or unstable housing. We do have some next steps. We're working on a PCA right now to identify whether variability or magnitude contribute more to mental health emergencies. And we're also working on some cause-specific analyses. So these results that I've been presenting are looking at any encounter with the BEST ED. So we're not categorizing encounters based on why a person went in or the ICD code for their visit. But that's something that we plan to do in the future with these analyses. All right, and so with that, I think I'll leave it here. Thank you again for listening and for the invitation to join today. It's been a great pleasure to speak to you about some of this work, and looking forward to the conversation that we'll have in the next 15 minutes or so.
Dr. Burrows, thank you so much for that outstanding presentation. And as someone who is on the receiving end of these ED psychiatric visits, I can tell you that it is, in my opinion, just the tip of the iceberg, right? That the people who come to the ED in crisis are a small population of the people who are experiencing mental illness and suffering through it at home, not having transportation or the ability to come in for care. And often, in my experience, also presenting for other complaints, chronic pain, substance overdose, some other thing that isn't coded on their chart as, psychiatric inpatient admission. And yet I can tell you that what you're capturing is, I would definitely agree, is the tip of the iceberg. But being able to show that correlation between the heat and those events is very meaningful. And I appreciate all the work that went into that geocoding to really get that highly defined data. So I'm here to moderate questions. And for those of you who are on the webinar, go ahead and add any questions you have into the chat. I'm very excited to encourage a vibrant conversation here about this important topic. In the meantime, while people are typing into the chat, I'm curious, as someone who has looked at heat illness and health outcomes, did your geocoding help you to better identify urban heat islands? So seeing where are the parts of Boston where people are really experiencing more significant heat exposure than others? Because obviously we know there's a wide variability. You can see the background landscape of where we live, which is mostly forested green space in New Hampshire. And we have a certain protection in our community against this high heat. And we know that urban areas are far more at risk with these urban heat islands. But I'm curious, with your highly detailed geocoding, have you used that data to look at the urban heat islands and which communities are most at risk?
Yeah, so that's a great question. And I do not have an answer for that question right now, but we do have some analyses underway that are looking at this. So we're trying to do a couple of different sort of stratified analyses, looking at different neighborhoods and grouping by neighborhoods, because I think these types of findings have such important policy implications that we want to be really attentive to making sure that the findings are actually like interpretable for people who are themselves living in these places. So a lot of the analyses I do, we look at like zip codes or census tracts or census blocks. And like, I could not tell you what census block I live in. And while it is like nice to have that granularity, we're trying to scale up to the neighborhood for some of those analyses so we can actually tell people something that means something to them, right? So we are in the process of working on this now. So we're going to look at stratified analyses based on different neighborhoods to see whether that dose response relationship is stronger in certain places, and also looking at levels of greenness. So those things are going to be pretty correlated, we think. But just to try to understand better, so like in those neighborhoods that have, above average versus below average greenness, do you see pretty strong heterogeneity? And we do hypothesize that we will, for the reasons that you're talking about with the heat island effect. But we obviously now have this data to actually show it, and so we want to be able to test these hypotheses. So hopefully, at some point in the next like 6 months, 9 months, something like that, we'll have some data and results to share with you about that.
No, it's very exciting. My mind goes in so many directions when I think about how that data can be used to improve community health. You mentioned that Boston has a heat action plan, which piqued my interest. And I'm curious if you could tell us, speaking of public health interventions, what is that action plan? Is it by neighborhood? Are there certain communities that have a better action plan than others? I can imagine, certainly we know up here in New England, access to or northern New England, access to air conditioning, for instance, is almost none. Historically, you haven't needed it in this part of the country. I suspect maybe Boston has needed it a little bit more than us over time, but there's a lot of variability in who has access to that. And do those, communities where one might expect to have less access to, cooling options, are there differences in the action plan for certain parts of the community? I'm just curious what that action plan looks like. And again, thinking about neighborhoods and stratification of need.
Right. Yeah. No. So it's a really interesting and important point. And so I think a couple things. So one is that you brought up the idea of air conditioning, and I think that's a really important point here that I didn't mention at the beginning of this talk, but is really important for thinking about these types of analyses. I feel like I have talked about this before, and people have been like, okay, but why Boston? Like, why aren't you doing this in Phoenix? Like, why are we talking about New England? Like, why are you talking about a city that, yeah, it gets hot in Boston, but it doesn't get that hot. Like it's not 120 degrees. It's not right. But I actually think that that is kind of the point, right? So this historical lack of risk is what makes the city particularly vulnerable. I lived in Boston for many years. We never had central air. It was really hot during the summer. Those buildings were not designed to keep it cool. And also, like, infrastructure isn't designed to keep it cool, right? So you are waiting outside for the T or for the bus, right? You maybe have like a little bit of shelter over you, but like it's not air conditioned. You're not moving between air conditioned spaces. And so I actually think that like that sort of framing of the lack of historical preparedness is really important to understanding why we see such an increased risk. And some of my colleagues' analyses on these national level hospitalizations, psych ED hospitalizations, psych ED visits and hospitalizations tend to suggest that that is kind of true. Like we see worse effects in areas that are not historically exposed to these exposures. So slightly tangential to the question you asked, but I think it's just such a good point that I wanted to sort of
Really
frame
important
it.
point.
Yeah.
And hits home to us because, it
Right.
is absolutely true. I worry about our at-risk communities because historically we haven't had full weeks of, high humidity and 90
Hmm.
degree or even 100-degree days. And so, homes aren't prepared for that. Communities, people aren't prepared for that. So I agree with you. Whereas, my
Right.
friends in Phoenix live in AC, move from AC to AC, kind of the
Hmm.
same way we do at sub-zero temperatures.
Yeah.
We don't do that here. And I
Right.
do think that our communities are at a different risk because of the infrastructure. So I
Right.
think it's a
And so
really important
hopefully that can catch up in some ways. I mean, there are issues with air conditioning generally in
point.
terms of sort of exacerbating some of these issues, but that's
Yeah.
maybe a separate issue. But just in going back to your question about the heat action plan, so this is a citywide effort, came out of the mayor's office. They have done some neighborhood specific analyses. That redlining figure that I showed was from the heat action plan. So I do think that they are trying to think about like equitable solutions. Health is included as part of that, of course, but mental health is not, which I think is interesting. So they're
Mm.
focusing on physical health, which again, like very reasonable starting point, right? But it doesn't include mental health effects. And so I think that's an area where like I'd love to see some more mental health conversation as we start thinking about, more cities are creating these types of climate preparedness or climate resilience plans. And it would be great to see some of these mental health issues and considerations being like taken into account with those plans.
Um, I have two different thoughts relating to that. One is, I agree with you. It's unfortunate we sometimes have this separation between physical health and mental health. And again, my work in the emergency department tells me that it's a tragedy that we make such a distinction, and the two are, completely correlated. And the biopsychosocial aspect of human health, I hope we make some real progress integrating our health concepts in our, American healthcare system going forward. But I'm curious, there are many ways to look at how this mental health change under heat stress impacts communities. And I know there's been research as well in, both crime rates. There's actually a
Hmm.
nice recent scoping review on US crime rates under high heat days in US cities. And then even globally looking at, political instability and, increase in violence on even a larger scale than like individual crime related to heat. And I'm curious, with your focus on this mental health aspect, are you thinking about any correlations to, again, it's almost the rare and lucky individual who lands in the emergency department when they're having a psychiatric issue, and that may be manifesting in, many other ways, whether it's violence or crime or,
Hmm.
you can imagine all the different ways where this manifests itself on a social level. What is your team's thought on looking at those correlations?
Yeah, so I have some separate work where we're including some like aggression and violence as sort of similar outcomes, and especially in that work, looking at the impact of greenness, which is also associated with all of those things, right? So, sort of teasing out these causal pathways is really complicated.
Right.
And then on kind of the other side of the spectrum, I've been doing some more qualitative based work where we're talking to people about sort of their more like general subclinical mental health impacts, and we're finding that people are talking about increased stress about like paying their bills now that they have to run their AC, and like worrying about taking an Uber because they don't want to walk to work when it's 100 degrees, right? And so there are these kind of like low level stressors that I think we're really not capturing, right? Especially when we think about that like sort of iceberg framework, right? Those are the things that we're like not seeing at all. And that's maybe where we can intervene, right? I think that's an important part of sort of including some of this and working with clinicians and practitioners. And I saw a comment in the or a question in the Q&A about sort of sharing these results with practitioners and with clinicians. And so in this particular study, we're working with clinical partners. So we have folks in the best ED who are part of the study. We're doing some qualitative interviews with clinicians as well to talk to them about like, do they think about heat in the ED? Do they think about heat? Do they talk about heat with their patients? What do they know about the impacts of heat? And so we're using that sort of actual like interviews to create better strategies for talking to clinicians and sort of trying to help them think about these things. But then on the community side, I think like there is this sort of like preclinical mental health impact potentially. And that's, I think, where we need to start figuring out a better way to kind of like share strategies to help people cope, because that's potentially where we can intervene before things get to be so severe that someone is showing up in the ED.
And for those of you online, you'll have to forgive me. I was actually looking in the chat instead of the webinar questions. So I'm going to go now, go back and catch up with these wonderful questions that we had. And we'll start in order. So the first, we touched on a little bit in terms of, Phoenix versus Boston, but how do you think your analysis can be applied to other cities, and what differences and similarities might you expect with those comparisons?
Yeah, so I think we could definitely do this type of analysis in other places. These results are definitely not generalizable to other cities, right? Like that's the downside of doing like really like locally specific research. But I think the method could be. So we built this offline geocoder to actually like safely protect patients' privacy while we were doing our geocoding process. And that we're working on a methods paper so that that could be replicated in other states, and maybe we could do kind of a similar analysis. So I think I think that the method could be really transferable. I think some of the differences and similarities, like maybe are going back to this conversation we talked about like places that have historic heat exposures, who have different types of adaptation strategies, different intervention strategies. So we might see some variation there in terms of like how prepared places are. But I suspect that we could see sort of similar within city variation. And so hopefully, again, we'll have those results soon.
And you touched on the geocoding methodology, and Bo Chang actually has a great question. And this was something that was on my mind too.
Yeah.
Your methodology, you're operating kind of under the assumption that individuals are seeking their emergency care close to where they live. And yet I will say in my experience, particularly when we have our high heat days, a lot of the presentations are related to workplace heat exposure, outdoor workers, in particular, construction workers, landscape workers, etc. And so how do you think this thought about, are they presenting based on heat exposure near their home versus heat exposure at the workplace? How do you think that impacts your methodology?
Yeah, so it's a really great question. So the answer to the sort of like basic question is yes, that is what we're assuming, right? So we're saying that we think that the home is a reasonable place to like is a reasonable place to do the heat-based assessment. So we could obviously be having issues with like where people actually are at the time of presenting. That might vary a little bit like across the course of the day, for example. Like maybe it is more reasonable to assume for nighttime visits that that is where people are. There's obviously a logistical limitation in that like we don't have additional addresses. But one way that we plan to try to get at this question or try to answer that question is something that colleagues of mine have done in previous analyses that we want to replicate here is they've created like the subset of the data where people's home addresses and the hospitals are within a sort of like small buffer. So looking at places where that exposure is probably accurate, even if they're somewhere else, like they're probably nearby, and use that sort of subset analysis as like a sensitivity analysis to see if we're really seeing that much of an issue. So it's a really good question. It's one that we're continuing to sort of think through, and is definitely a limitation of these types of studies. Obviously, like what we'd love to do is like follow people around all day, right? And see like when they're in AC, when they're not in AC, where they are most of the day. But trying to get at it through these like subset analyses is like one of the only ways that I think we can try to address that question.
No, I think that that makes sense. And particularly in Boston, where there are so many medical
Mhm.
centers, here
Yeah.
it actually would be easier because we have one facility for a very big region.
Right.
Um,
Yeah.
and so that does make sense to use that subset correlation of, did you present to the hospital closest to your home residence, or did you present to one much further away? And does that mean you were working an hour away from your home and presented to the hospital closest to work? That
Exactly.
certainly could highlight some of those differences. Okay, and Derek Walker had a great question, and I think this taps in a little bit about our heat action plan we were talking about, is that,
Hmm.
could this research help to locate cooling centers and other climate resilience infrastructure? Again, looking at our neighborhoods that maybe have more of that built-in infrastructure, are they doing better with their ED presentations than others that don't? And is there work that you're aware of to correlate mental health distress with other climate-related localized impacts? So again, can we actually start to see maybe positive outcomes from these climate resilience interventions?
Hmm. Yeah, yeah. So this is a great question. So the answer is absolutely, we could use this type of research to place cooling centers or identify sort of target communities for additional interventions. One thing that I think is really important is that we've done some qualitative work both in Boston and in Chicago where we've talked to people about cooling centers. And we're finding that they don't always use them. One, because they're located in like really bad places. Like you're not going to walk a mile and a half if your cooling center is not located on a bus route and you're far away. Like you're just not going to go. Likewise, we've heard from parents that they're not going to go if there aren't things to sort of keep their kids occupied because they're like, I can't take a 3-year-old and just like have it scream at me all afternoon, right? So like, I think that's actually going to be really important as well. So I'm hesitant to make sort of policy recommendations like this about like, yes, quantitatively, I could tell you probably where the best place to put in cooling center would be, but then I think what we need to do is build in some of this additional like community-based knowledge of like, okay, where are people actually going to go to the cooling center? Because just having it doesn't necessarily help us. Um, and then to the second part of this question, I think there's a lot of interesting work that's trying to get at some of these other types of climate related stressors. So we also have like I've done some research on air pollution and mental distress, on residential greenness, and some of these other types of like flooding, like localized flooding, lots of different types of exposures that we see have both positive and negative influences on mental distress and mental health. And I think something that I think about a lot is like that people are really experiencing all of these things in sort of totality. And so some folks doing more like exposomic type research of saying like what is the like whole environment that you were experiencing. And so I think at some point we'll need to move the field more towards thinking about like the sort of combined hazard, the co-occurring hazard, the total experience of the environmental exposure to try to like really understand what's happening to people because they're not experiencing extreme heat in isolation, right? They're experiencing it in conjunction with lots of other social and environmental factors.
Well, Kate, this has been an amazing presentation. I'm so grateful. I have so many more questions. I will say, I hope that someone, either you or someone from your team, can come back and talk more about the greening
Mm.
interventions and the green space research. That's obviously as a wilderness medicine and nature as a healthcare intervention, a big part of my interests. And I would love to hear more about that. I will say I was actually just in Chicago in March at a global health conference and looking out at that cityscape, which is very different than the landscape that you're seeing behind me. All I could think about is all the different ways we could grow green things on those buildings and change the human experience. So I would love to hear more about that research that your team is doing on, green space in human, and particularly in urban areas, and how we can use that as an intervention. As you say, I think that it might be hard to get as a mom of 4 kids myself, to go hang out in a cooling center inside. But if there's shady trees and swing sets and sprinklers, then that would probably be a much better draw. And how do we create those types of, community specific interventions that will really work for the people who need it most? So excited to be able to hear about this research, and I hope that these conversations will continue both on our campus and in your cross-institutional efforts, so that we can really tackle some of these wicked problems, as we in Boston and New England like to call them.
Great.
Well, thank you so much for listening and thanks for moderating, Sarah. It was really great to speak with you all.
Thank you so much, Kate and Sarah, for Kate, thank you for a fantastic talk. It was really great to have you here, and we will absolutely be following your work and look forward to seeing what you do. And very glad to have you. So thank you for that really great talk and the important work. And Sarah, thank you for moderating a really great discussion. So wonderful to have you all. I just have a couple of quick notes before we close out. So thank you again all for being here. We do have one more talk coming up for our series for this year. We'll have Wilson Ricks on May 14th. He's a postdoc in the Zero Carbon Energy Systems Research and Optimization Lab at Princeton. He's going to be talking about next generation geothermal power and its role in the energy system. That'll be moderated by Professor Erin Mayfield, who is at the Thayer School of Engineering here at Dartmouth, who was also in the same lab at Princeton at one time. And was a speaker here on the series. So looking forward to that. And then we'll be taking a break for the summer and move back in the fall with some other speakers. So keep an eye out for updates on that. And thank you again so much to Kate. We're so happy to finally get you here and hear about the great work that you're doing, and looking forward to staying connected with you. And thank you again to Sarah for moderating. And we will see you all again. Thank you.
Bye. Thanks, everyone. Have a nice